Hi everyone, thanks so much for joining today. My name is Cassie Sedgwick and I'm a clinical pharmacist practitioner at the Madison VA, and I'm joined in this presentation by Amanda Margolis, an associate professor at the University of Wisconsin-Madison School of Pharmacy, and Clara Nickel, a fourth-year pharmacy student at UW-Madison School of Pharmacy. Today we'll be discussing quasi-experimental research design. Myself and Clara Nickel have no relevant financial relationships with ineligible companies to disclose. However, Amanda Margolis does report relevant financial relationships with an ineligible company as a research partner. However, that work is not related to the content of this presentation. The learning objectives for this presentation are to describe when quasi-experimental research design is used compared to traditional experimental research, to differentiate between the major types of quasi-experimental research design, identify strengths and limitations of propensity score matching and interrupted time series, and analyze a quasi-experimental study using a critical appraisal checklist and decide if it applies to practice.
Hello everyone, my name is Clara Nickel and I will be starting us off with an overview of quasi-experimental research. The prefix quasi means resembling. Quasi-experimental research is research that resembles experimental research without being true experimental research due to the lack of randomization. The aim of quasi-experimental research remains the same as traditional experimental research, which is to assess causal relationship between independent and dependent variables. Quasi-experimental research is becoming increasingly popular in medical literature, so the ability to understand and assess a study is important to ensure that you have the right skills to determine how the results of these trials can be applied to clinical practice. These are some of the main examples when you might see quasi-experimental design used in literature. The first is when it is unethical to randomize. We wouldn't want to randomize patients to an intervention to see if it causes harm. A lot of the time in quasi-experimental research, patients choose whether they receive a particular intervention or procedure, or we go back into the medical record and then utilize statistical approaches to minimize bias. So, in situations where it is unethical to randomize, quasi-experimental research may be able to fill in gaps in knowledge or help us answer questions that we otherwise wouldn't be able to using traditional research. The cost of randomized controlled trials are very high, especially when considering many involve multi-center approaches, and utilizing quasi-experimental design may help us reduce this cost. Oncology prevention trials are generally very long and could be costly to conduct, so much of that is observational or quasi-experimental. Evaluation of a new program, service, educational material, or workflow can also be difficult to randomize or have a control group. When a service is being implemented across a department, randomization is often not feasible. Lastly, first performing a quasi-experimental research study can start to establish a causal relationship and may produce data that would support funding for a larger RCT. Strengths of quasi-experimental research design include higher external validity because the study population more closely mirrors the general population, and as we discussed on the previous slide, these studies allow for causal relationships to be studied when randomization is not possible and are generally lower cost and less time consuming. On the other hand, limitations of quasi-experimental studies include lower internal validity, since there is greater room for bias to occur, and additionally, sometimes the time point for when the intervention occurred is unclear, which can make it difficult to determine what data may be considered pre- or post-intervention. If you are doing a post-test study only, it can also be unclear if the outcome you are measuring was present prior to the intervention, or if the effect was truly due to the intervention itself. Some of the bias that gets introduced in quasi-experimental design includes selection bias, since randomization is not used. There are likely factors that may cause participants to be selected to receive an intervention or not, which is not seen if randomization is used. This can cause for greater differences between the intervention and comparator. Historical bias occurs when other events might be competing with our intervention and may be contributing to the outcomes we are seeing. For example, if we want to evaluate patients that are being seen in a new COPD clinic, but many of those patients are also enrolled in a COPD education course, it can be difficult to determine if their increase in proper inhaler use was due to the clinic or the education course. Finally, sometimes tests change over time, especially if you are following patients for a long period. This can result in instrumentation bias. For example, we might switch to newer technology or new tests, which could make it difficult to compare data collected over time. Here is an overview of the differences seen in traditional experimental research, or RCTs, and quasi-experimental research. In RCTs, participants are always randomized to study groups, and interventions are often double-blinded. These types of studies require a control and a treatment group. Quasi-experimental research, on the other hand, participants are not randomized and blinding is far less likely, since many times participants or clinicians are choosing the intervention. Control groups are also not required in quasi-experimental research, though sometimes are used. When comparing level of evidence for quasi-experimental research to other types of research design, you can see that it actually falls quite high on the pyramid. Experimental studies such as systematic reviews, meta-analyses, and RCTs are at the top of the pyramid, but below that are quasi-experimental studies. Observational studies fall below quasi-experimental research, which include observational analytic design, such as cohort studies and case-controlled studies, and observational descriptive studies, such as those cross-sectional studies, case series, and case studies. Expert opinions have the lowest level of evidence. For the remainder of the presentation, we will focus on quasi-experimental studies. We have come to our first learning assessment. I will briefly read the question and each of the following responses. Please feel free to stop the video if you would like to allow some time to think through the question and come up with a response. Which research scenario is most appropriate for quasi-experimental research design? A. Evaluation of efficacy and safety for a new medication for use in diabetes. B. Evaluation of patients exposed to secondhand tobacco smoke on rates of lung cancer. C. Evaluation of a new FDA-approved antibiotic used to treat urinary tract infections compared to nitrofurantoin. Or D. Evaluation of the efficacy and safety of a change in the antibiotic ordering process in an emergency department to minimize antibiotic resistance. I will give you a couple minutes to think about it, and then we will move on to the next slide with the answer. The correct response to this learning assessment is D. Evaluation of the safety and efficacy of change in antibiotic ordering process in the emergency department to minimize antibiotic resistance. It is most appropriate for quasi-experimental research since it is evaluating a change in process throughout an entire department. This process would not be possible to perform an RCT due to the inability to randomize as ordering process is changed for the entire facility. The strongest form of evaluation in this case would be a quasi-experimental design. Now we have come to our second learning assessment. Again, I will pause and read the question. Feel free to pause the video and think about your time before moving on to the next slide. True or false? Quasi-experimental research design has a lower level of evidence than a case-controlled study. A. True. B. False. The correct response in this situation is false, because quasi-experimental studies have higher levels of evidence than a case-controlled study. Next, we will go into describing different types of quasi-experimental research. The three main types of quasi-experimental research that we will discuss are pre-test, post-test, interrupted time series, and propensity score matching. Of note, many studies use a combination of these designs. Here is a brief overview of each of the main types of quasi-experimental research. We will begin by discussing the pre-test, post-test design. Pre-test, post-test design can include a single group or utilize multiple groups with an intervention and control. The factor that differentiates pre-test, post-test from interrupted time series is that the dependent variable is only measured once before, unless the design is post-test only, and once after the intervention. The top image depicts a single group post-test. As you can see, the group experiences the intervention, and then an observation is taken at some point after the intervention has occurred. This is also considered to be the weakest form of quasi-experimental research. The bottom image depicts a single group pre-post, where one measurement is taken both before and after the intervention. There are many flaws in this type of study design, as you can imagine, such as lack of repeated testing or Hawthorne effect, which is where individuals may act differently or modify their behavior in response to being observed. And of course, there is no control group to compare this to. This can make it difficult to determine if the effect you are seeing is from the intervention, some co-occurring events, or if the outcome would have occurred without the intervention. Though this type of study design is weaker, it may be a good place to start if you are doing a pilot and trying to see if your intervention has any effect at all. In both scenarios, there is no randomization and no control or comparison group. Not included in this image, you could also have a pre-post test design that has one observational point prior to the intervention and then multiple outcome measures after. This is how they do phase 1 drug studies, where they are checking pharmacokinetic and adverse effects.
Next, we'll discuss interrupted time series. An interrupted time series is quite similar to a pre-test, post-test, though multiple data points are collected for dependent variables before and after the intervention. Essentially, you have a timeline of outcome measures that's interrupted by the intervention. Here's an example of what a single group interrupted time series might look like, where there are 3 measures of the outcome before and 3 after the intervention. And here's an example of what the data might look like from a single group interrupted time series. So this is from a facility that was assessing the percentage of blood culture contamination before and after a full sterile process was implemented in the emergency department. As you can see, there are multiple data points before and after, which allows for a trend to be established. Interrupted time series also relies on extrapolation to estimate what the post-intervention data would have been without the intervention. This helps to determine the impact or the difference that the intervention had on the outcome in question. As you can see in the figure on the right, the extrapolation is a continuation of the trend line at baseline and is shown via the dashed line. The difference between the outcome line post-intervention, shown by the solid line, and the extrapolated line shows the perceived impact of the intervention. Single group interrupted time series can also be done with multiple interventions. In this study, a full sterile process was implemented in Hospital B, which resulted in a greater percentage of blood cultures that were contaminated, and then it shows the data after a modified sterile process was put into place. So this type of study design could be useful when trying to implement and improve services or workflows where you're taking data after the first change and then trying to make improvements to see how that impacts the result over time. Interrupted time series can also include a comparator group that did not receive the intervention. Though as previously described, these groups are not randomized. Generally, the clinicians or participants choose whether or not they receive the intervention. And here's an example of what a figure might look like for a research study that utilized a comparative interrupted time series. The purple line on the top is depicting the intervention group, while the blue line on the bottom depicts the control group. As you can see, there may be differences in the data collected pre-intervention between the two groups, and this could be due to differences in baseline characteristics between the two groups. Using a comparator group can help distinguish the effect of the intervention from other co-occurring events. This can help reduce historical and instrumentation bias. So we can take the difference in the extrapolated data line and the collected post-intervention data from the control group and consider that to be the difference that's caused by the co-occurring events. This can then be used in the intervention group to help determine what change in outcome is likely due to the intervention and what change was likely caused by the co-occurring events. Strengths of interrupted time series include the ability to establish a temporal relationship and also increase stability in measurements with multiple pre- and post-intervention measurements. So there's more stability with the multiple measurements when compared to a pre-test, post-test design. Then, as mentioned on the previous slide, comparative interrupted time series can help distinguish intervention effects from co-occurring events, though notably if intervention and comparison groups are different at baseline, historical or instrumentation threats may not impact each group to the same extent. Therefore, historical and instrumentation bias are still limitations in comparative interrupted time series. Other limitations include that sometimes the time point of the intervention is not specific. There may also be a weak or delayed impact of the intervention, so although you have the time point that the intervention occurred, you actually might not see the impact of that until after the end point of the study. This can be a problem since interrupted time series are often short and only have a few pre- and post-intervention measurements. So if there is a weak or delayed impact of the intervention, again, it might not be captured within the study. Varied implementation also contributes to the time point of the intervention not always being clear. For example, if there was a formulary conversion at a hospital or within an insurance company, though there's a specific date that the formulary conversion took place, patients might still be finishing up home supplies of medications and likely will have variable supplies remaining, which would impact when they started the new formulary preferred agent. There are ways to strengthen interrupted time series and reduce the impact of bias and address some of the potential limitations. One way would be to control the time point of the intervention. This could be choosing to intervene when threats to the intervention are less likely, and also to collect more pre-intervention measurements and post-intervention measurements. You can also match treatment and comparison groups based on covariates such as age, socioeconomic status, and exclude some outliers to increase similarities between groups. This can be done through multivariate or propensity score matching. Now we'll talk a little bit more about how we would do propensity score matching or how propensity score matching is done in these studies. Propensity score matching is sometimes referred to as non-equivalent control group design. This compares groups that were not established randomly, such as when participants choose their own treatment or choose whether or not they're enrolled in a specific service, or when an investigator or clinician plays a part in deciding whether participants get a certain intervention. Propensity score matching is used to compare groups where an intervention occurred and is effective at researching already existing groups. These are statistical techniques that help to minimize potentially confounding variables. Here's the layout of a typical randomized controlled trial, which I'm sure we're all very familiar with. In these studies, a group of participants is randomized to be in the intervention or control group, and dependent variables are subsequently assessed. Generally, participants are randomized and stratified based on specific covariates, so you end up with two groups that look pretty similar. On the other hand, here's an example of what a traditional cohort study design looks like. This is where groups of patients sharing some characteristics are followed over time, and at some point, certain individuals may be exposed to some risk factors, and the impact of the exposure is measured over time. The intervention and the control group are often quite different at baseline, as certain characteristics may predispose participants to certain risk factors. So this is shown as one group is shown in green and the other in black, illustrating that they are different. So this can make it difficult to determine what impact is caused by the exposure versus the differing baseline characteristics. Propensity score matching aims to create more similar groups at baseline by matching participants based on certain covariates without using randomization. So these groups exist on their own, so participants are either get the intervention or don't, but propensity score matching selects certain participants who share similar covariates and exclude outliers so that the groups appear more similar. A propensity score is defined as the conditional probability that a subject belongs to the treatment group given observed covariates. There's multiple ways to use propensity scores, but for the purpose of this presentation, we'll solely focus on propensity score matching. Of note, there are many different ways to calculate propensity scores and do the matching, and a statistician should always be involved given the complexity. As previously discussed in quasi-experimental research, researchers do not control which patients receive treatment, and many factors may influence whether a patient receives treatment, which results in differing baseline characteristics. Propensity score matching helps to identify patients or participants that are more similar at baseline and can minimize the impact of confounding variables. The covariates, which are used to match participants, are selected based on input from the investigators. These are the major steps to conducting a propensity score analysis. So first we determine what the dependent variable is. This is the primary outcome of interest and likely what we design the study around. Next is to select covariates, or all of the variables that we want to have more balance in our analysis. This could be anything that the investigator may suspect would have an impact on the outcome. This could be age, disease states, concurrent therapies, or any baseline characteristics normally seen in Table 1 of studies. The aim of this is to make the groups as similar to as if they were randomized as possible. The next piece is the propensity score estimation. To do this, we try to build a model to predict whether the participants would be in the intervention group or not. Each participant is then assigned a propensity score, which again is their likelihood or propensity to be in the intervention group. Next, we match based on the propensity score, which can be done again in many different ways, and new ways to do this continue to arise. And there is some discrepancy on what the best way is to perform this matching. The important thing is that we match based on propensity score and not on individual covariates. So again, the propensity score takes into account multiple covariates, not just single covariates. The unmatched participants tend to be excluded from the analysis as there's no one in the other group that has the same propensity to be in the intervention group as they do. For example, someone in the intervention group who has a very high propensity score or likelihood of being in the intervention group may not have a match to a participant in the control group who also has a high propensity for being in the intervention group. This can also be true for participants who have an extreme likelihood of being in the control arm. There may not be a participant who matches in the intervention group that has that same likelihood of being in the control arm. Although this does help to minimize bias and can help us better determine what the impact of our intervention is, this decreases the generalizability since we are removing people from our analysis, though we are not removing them again based off of any one specific characteristic. So it decreases the generalizability. However, it's hard to figure out who the decreased generalizability applies to because we're not removing people based off of just one specific characteristic. So it can be difficult to determine what about these people made their propensity score so extreme that they were unmatched. The last step is to estimate the treatment effect, which can be done also in several ways. The main point to take away from this is that propensity scores are done by a statistician using logistic regression to predict who would be in the intervention group. We then match participants based on the propensity score and estimate the treatment effect. And this is all done to minimize selection bias. So here's a visual example of what propensity score matching may look like. So here we have many participants in each group with differing baseline characteristics. A propensity score is calculated for each participant and is illustrated in this image by the size of the person. The larger the image, the greater the likelihood that they would be in the intervention group. We then match participants based on propensity scores. So again, in this image, it's demonstrated by the size of the figure. As you can see, all participants in the intervention group have someone that they're matched with in the control group that has the same propensity as they do to be in the intervention group, or the same propensity score that they do. The participants who were excluded either have a very high propensity score or a very low propensity score and didn't have anybody that they matched with in the other group or who had the same propensity score as they did. So this leaves us with intervention and control groups that are more similar and can help us to reduce those confounding variables or those differences in baseline characteristics. So now we'll talk about some strengths and limitations of propensity score matching. So one strength of propensity score matching is that it actually can be blinded. So this is done if you have two statisticians, with one calculating the propensity score and the other calculating the intervention effect. It also helps to minimize bias, which is why we use it in study. We do this to minimize the effect of covariates and minimize the differences in people choosing the intervention versus control, or people choosing treatment A over treatment B. Some of the limitations of propensity score matching is that the best methods for balancing and matching based on propensity score are still being determined. And then, as previously mentioned, this results in lower generalizability of the study since we are removing participants from the study. So I've included an example from the literature where propensity score matching was used to evaluate hazard ratios of patients with atrial fibrillation receiving either rate or rhythm control. So the results were similar when done in all patients compared to when propensity score matching was utilized, as shown on the left. The investigators reported performing an analysis with propensity score matching to control for potential residual confounding bias. But you can see on the right the impact in baseline characteristics. First, you'll note that there were a greater number of patients in the rate group versus rhythm, so they must have used a one-to-one matching. You can see that after matching, there was less statistically significant differences noted in baseline characteristics, which is the purpose of propensity score matching. Next, we'll move on to our third learning assessment question. So which study design does the following study describe? A checklist for checking chemotherapy infusions is implemented in an inpatient pharmacy. Error rates and near misses are reported monthly, and data is available over the previous 3 years. 1 month after the implementation of the checklist, error rates and near misses are collected again, and a month after implementation, the effects of utilizing the checklist are evaluated. Is this A, pre-test, post-test, B, regression discontinuity design, C, interrupted time series, or D, cohort with propensity score matching? So the answer to this learning assessment is C. This would be an example of an interrupted time series, as there are multiple data points prior to the intervention and they'll be able to continue to collect data monthly after the intervention was implemented. And now we have our fourth learning assessment question. So which statement regarding bias is specific to an interrupted time series? So A, the time point of the intervention is not always clear. B, low generalizability is specific to the time of the intervention. C, interrupted time series has lower power than a randomized controlled trial. Or D, in interrupted time series studies, researchers are unable to use a control arm, which reduces selection bias. The answer to this learning assessment question is A, the time point of the intervention is not always clear. As previously mentioned, there are certain things that may impact whether or not an intervention is implemented. So even though we have the date or the specific time that the intervention was supposed to occur, that's not always when it was implemented or when it actually occurred. And our fifth learning assessment question, what is an advantage of using propensity score matching? A, there are clear methods available for balancing propensity score. B, propensity score matching increases generalizability of cohort studies. C, you do not need to be concerned about other potential forms of bias, such as historical bias or attrition. Or D, statisticians are able to blind propensity score assignments when calculating intervention effect size. So the answer to this question is D, statisticians are able to blind propensity score assignments when calculating the intervention effect size. So as mentioned on the strengths limitations slide, if one statistician calculates the propensity score and the other calculates the intervention effect size, we are actually able to maintain blinding.
Hi everyone, this is Amanda Margolis. I'm going to review the last section of this presentation where we're going to discuss critical appraisal tools and apply a critical appraisal tool to a quasi-experimental article. There are a number of different critical appraisal checklists. The ones on this particular screen are for randomized controlled trials, and in general, especially if you're newer to reviewing literature, either a student, resident, or new practitioner especially, I would highly recommend the use of a critical appraisal checklist when reviewing any article, at least until you're pretty sure of the things that you look for and you're pretty systematic about it. But what's nice about these critical appraisal checklists is that they are designed by very reputable institutions, and a lot of times they can also give some guidance on what you're looking for and why it's problematic if a study deviates from the gold standard. So the Joanna Briggs Institute and the Center for Evidence-Based Medicine are two of the institutions who create and manage a number of critical appraisal checklists that we'll review on the next few slides. This slide lists all the different types of critical appraisal tools that the Joanna Briggs Institute manages. Of particular note for this presentation, you'll see that they do have a critical appraisal tool for quasi-experimental studies. And then on this slide, we have the critical appraisal tools available from the Center for Evidence-Based Medicine and the Critical Appraisal Skill Program. Real quick note, under the Center for Evidence-Based Medicine, an IPD review is a critical appraisal checklist for individual patient data within a meta-analysis. This is the critical appraisal checklist from the Joanna Briggs Institute, specific for quasi-experimental studies. You can see that it's 9 questions long, and for each item it gives you a yes, no, unclear, or not applicable, but it gives you specific things to think through, and each of these things would indicate a well-done trial, or maybe if there are issues within that trial. They do give a not applicable because this is a pretty general checklist for quasi-experimental studies. It's not specific for interrupted time series or propensity score matching or, again, a specific type of study. And so they needed to be somewhat broad given that it's looking at different methods of quasi-experimental research all within the same checklist. But this is a pretty well done, comprehensive checklist for when you're reviewing quasi-experimental research. The example article we're going to use is the efficacy and safety of U500 insulin in patients transitioned from conventional insulin therapy. This article is being reused with permission from the Journal of the Pharmacy Society of Wisconsin and the primary author. This article was selected in part because it was published through PSW. It was also selected because it's on the shorter side, so it's a good example article to use for you to have time to briefly review it and look at it alongside the critical appraisal checklist. So at this point, the presentation will pause, and I would encourage you to pull the article. It's posted with the presentation materials. Take a minute and just skim through it, especially the methods section. And then when you're ready, you can press play so that we can continue the presentation. So keep in mind that when this study was published in 2016, there was very limited data on how U500 behaved among patients with severe insulin resistance and how U500 would work and how safe it was in practice. At the time the study was started in 2013, there was a single prospective study of 11 patients and a handful of small retrospective studies. So there wasn't a lot of data available, and therefore it was desired to see how this actually worked in our own patients at the Madison VA. So as far as the resources we had available, it was reasonable to do a single-arm retrospective chart review. That was about the resources we had, right? So you're seeing we don't have the resources for a randomized controlled trial. We're not even talking about the resources in time to have a control arm here, so single arm. But in order to make it a more robust observation, we were able to do it as a quasi-experimental design and include a short interrupted time series to give it those trends and make it a little bit more robust than just a pre-post, just before and just after the U500 use. So the goal of this trial was to assess the impact of U500 on veterans with type 2 diabetes, again, transitioning from the traditional or conventional insulin therapy. As I stated earlier, the study was conducted at the William S. Middleton Memorial Veterans Hospital in Madison, Wisconsin. There were a total of 122 patients who met the inclusion criteria. To meet the inclusion criteria, patients had to be on U500 at the Madison VA for at least 3 months, and we had to have pre-U500 data. And in order to receive U500 at the time at the Madison VA, you had to be on at least 200 units of conventional insulin, have good adherence, pass a checklist of understanding and ability to draw up the insulin. So we had to have pre-data and at least 3 months, at least that initial data point post-data. A single investigator conducted the chart review, and this included both pulling out some labs and reviewing notes from especially our endocrinology and diabetes clinicians. And then the data was collected every 3 months for 2 years, both pre and post transition to U500. The primary outcome in the study was the change in hemoglobin A1C. Secondary outcomes included changes in daily insulin doses, the number of insulin injections per day, the frequency of hypoglycemic episodes, body weight, and emergency department visits related to diabetes. We're now on learning assessment number 6 for the presentation, which is the first question from the Joanna Briggs Institute Critical Appraisal Checklist. So for this study, is it clear in the study what is the cause and what is the effect? i.e., there is no confusion about which variable came first. Yes, no, unclear, or not applicable. In this case, I would say yes, it's very clear that the date of the transition to U500 is known for each individual, and we can figure out what was the A1C prior and what was the A1C after. Because we're at a single institution and these patients are working with single either diabetes clinicians or endocrinologists for their U500. So in this case, we had that data housed within our institution and could pull that. So I would say yes. And that was, I believe, clear in the manuscript as well. Now we move on to learning assessment number 7, which is the Joanna Briggs Institute Critical Appraisal Checklist question number 2. Were the participants included in any comparison similar? The answers are yes, no, unclear, or not applicable. In this case, the answer is not applicable. Like I mentioned earlier, this is a single arm study, so there is no control arm, and it's the single individual before the transition to U500 being compared to the after U500 data. I did, however, include the baseline characteristics in case you're interested in the description of the patient population included in this study, especially if you want to compare it to patients at your own institution from more of a generalizability standpoint. Learning assessment question number 8 is Joanna Briggs Institute Critical Appraisal Checklist question number 3. Were the participants included in any comparison receiving similar treatment care other than the exposure or intervention of interest? So in this case, I selected yes, because all of the participants are receiving care at a single medical institution. I think it would also be reasonable to select not applicable, because there's no comparison here, that we don't have that control group. But if you think of the comparison as the pre-post, yes, all of the individuals were pretty similar. I did also include the information, it was on the previous slide with the participant baseline demographics, but about 53% of patients were on metformin, and one patient was on rosiglitazone at baseline. That gives you a sense of the therapy as we were using at the time. But I would also argue there's maybe some limitations here, because as we know, these were the medications at baseline. We know that this can change over time, and we didn't necessarily collect what were they on 2 years ago or 2 years after U500 use began. Moving on to learning assessment question number 9, which is the Joanna Briggs Institute Critical Appraisal Checklist question number 4. Was there a control group? Yes, no, unclear, or not applicable? We've discussed on a few instances regarding this example that there was not a control group, given that it was a single arm pre-post short interrupted time series. Learning assessment question number 10 is the Joanna Briggs Institute Clinical Appraisal Checklist question number 5. Were there multiple measurements of outcome both pre and post-intervention exposure? Yes, no, unclear, or not applicable. And I included figure 1 in this case so you can see some of the data that was included in the publication. The answer in this case is yes. As we mentioned earlier, this information was collected every 3 months for 2 years, pre and post U500 transition. The outcomes that we did the short interrupted time series for included hemoglobin A1C, hypoglycemic episodes per week, the insulin dose, and the body weight in pounds. Now, one thing to note is this gives us about 8 time points pre and post, which is considered pretty small for an interrupted time series. Now we're moving on to learning assessment number 11, which is the Joanna Briggs Institute Critical Appraisal Checklist question number 6. Was the follow-up complete, and if not, were differences between groups in terms of their follow-up adequately described and analyzed? In this case, I would actually say no, that follow-up was not necessarily complete. In order to get into the study, participants had to be on their U500 for at least 3 months, but they didn't have to be on it for the full 2 years of time, or they could discontinue it at obviously any time, given it's a retrospective evaluation. So follow-up was completed when the investigator was able to, but you can see on below the year in this figure, it gives you the N at each time point. And you can see by the end of 2 years, there was only data for 55 participants. Now, clearly it's not difference between groups because it's only one group, but you can also see that we did not have full follow-up for this evaluation, which is a limitation. Moving on to learning assessment question number 12, which is question number 7 on the Joanna Briggs Institute Quasi-Experimental Critical Appraisal Checklist. Were the outcomes of participants included in any comparisons measured in the same way? Yes, no, unclear, or not applicable? In this case, I would say yes. The outcomes were measured within a single institution within a relatively narrow period of time, and it was the same investigator doing the data abstraction, so it should be consistent throughout all of the participants evaluated. Learning assessment question number 13 is question 8 on the Joanna Briggs Critical Appraisal Checklist. Were outcomes measured in a reliable way? Yes, no, unclear, or not applicable? In the example study, I would describe the outcomes measured reliability to be unclear. And I say this because the labs pulled out of the medical record were probably pretty reliable, single investigator, we're just abstracting quantitative numbers, but there's also some more qualitative pieces of information being collected from notes, such as how frequently people were going to the ER and was it for a diabetes-related concern, or we were collecting episodes of hypoglycemia per week, and that might have come out of the subjective information from the clinician's notes, or it might have come from reviews of whatever the clinician chose to include in the note regarding their glucose meters. So it may not be consistent. Ideally, in this case, we'd have at least 2 investigators abstracting data out of the medical record and then giving us data on how consistently that information is collected between the 2 individuals. And that would give us a more robust, reliable way of collecting information. So it doesn't mean it's wrong, but it means that there's maybe some room for improvement in how this could have been done when the data was collected. We are at our last learning assessment question, which is question number 14. And this is also the last question on the Joanna Briggs Institute Critical Appraisal Checklist for Quasi-Experimental Studies, which is question number 9. Was appropriate statistical analysis used? Yes, no, unclear, or not applicable? I'm going to say yes in this case, but I'm also going to admit that I'm incredibly biased in this case because I did the statistical analysis. That said, in re-reviewing this article, there are probably more details, especially on how the interrupted time series itself was calculated and generated, that I could have included within that section to at least give more information to the next person. So how would we consider the overall appraisal in this case? Well, again, I'm biased given that I'm one of the authors, but I would say that it's well done for a single-arm, retrospective, short, interrupted time series. Again, this does give us a stronger design than a simple pre-post study design with data trends. What I'm asking you to consider is, what if we just did the single A1C prior to starting U500 and the single A1C after starting U500? Having 8 time periods to build up trends before to see where we're going, and then having those 8 time periods after to see how it normalizes over the course of 2 years is a stronger study design than that simple pre-post 3 months before and 3 months after. That being said, we've discussed some ways that this study design could be improved. We could add a control arm. We could add more time to the pre and post transition of U500. We could only include participants that have had at least those 2 years of time or whatever time frame we're using to make sure we have more complete data collection across all of the individuals on U500. And we could put in some quality control measures for data collection and then describe those within the manuscript. All of those would create a stronger interrupted time series. For our study conclusions, for the time this study was conducted, there was very limited information on U500 outcomes in practice, and this was one of the larger reviews when it was published, and has since been included in several systematic reviews and meta-analyses. It is consistent with other reports that there's a decrease in hemoglobin A1C by at least 1%, but that's at a trade-off with an increase in hypoglycemia. The data described in this study is likely a reasonable estimate of the effect of U500 among this patient population. In summary of the larger presentation, quasi-experimental studies may be used when randomized controlled trials are not ethical or not able to be completed for cost or due to the nature of the intervention. Common quasi-experimental research designs include pre-test, post-test, interrupted time series, propensity score matching, or can be a combination of these designs. Propensity score matching can help to reduce biases, and critical appraisal tools can be used to assess the quality of a quasi-experimental study. These are our references. Thank you for listening to this presentation. Here is the contact information for myself, Cassie Sedgwick, and Clara Nickel if you have any questions on this content. We hope you have a nice day. Thank you.